So first of all, thank you very much for this invitation to be amongst you for this program. And again, I congratulate you for arranging this webinar conference, because you are one of the best, not just a great interventional cardiologist across all spectrum of cardiovascular issues, and also a great, organizer. So, and also respected chairpersons and my dear friends. So balloon mitral valvuloplasty continues to be the choice procedure for symptomatic rheumatic mitral stenosis. And of course, the two important key steps of performing a successful balloon mitral valvuloplasty would be a transseptal catheterization and also crossing the mitral valve. These are the two key steps of performing a successful balloon mitral valvuloplasty. I will just embark on some of the important issues before actually embarking on transseptal puncture, the tips and tricks of transseptal puncture and balloon mitral valvuloplasty. The indications would be morphologically suitable mitral valve and severity of mitral stenosis and symptoms. These are taken into considerations. So the indications for balloon mitral valvotomy is severe mitral stenosis less than 1 centimeter square. Although this indication differs from standard American Heart Association or ACC, where up to 1.5 they consider as moderate, but particularly in India with a body surface area less than 1.7 or 1.6, even the mitral stenosis mitral valve area less than 1 centimeter, even 1.3, between 1 to 1.5 we consider moderate, less than 1 we consider as severe. So other indications would be pulmonary hypertension, episodic pulmonary edema, thromboembolism in moderate to severe MS, and pregnancy with mitral stenosis. So as our expertise has grown, and the expanding indications for balloon mitral valvuloplasty would be mitral restenosis, either a prior balloon or a prior closed mitral valvotomy, and mitral stenosis with left atrial thrombus. There are some types of LA thrombus still using some special technique and can do a balloon mitral valvuloplasty despite a left atrial thrombus. Then also other subgroup where when the mitral stenosis is associated with more than moderate MR, there are some special subset, we can still do that. And hybrid therapy, particularly if patient has got severe aortic regurgitation and a balloonable mitral stenosis, we can always do a balloon for the mitral valve, then a surgeon can fix the aortic regurgitation. This is basically to convert a double valve replacement into a single valve replacement. And so also same thing, for example, patient has got a balloonable mitral stenosis and angioplastable coronary artery disease, then we can do a balloon for both. These are some of the expanding indications. So the contraindications would be left atrial body clot and mitral regurgitation more than grade 2, and selective bicommissural calcification is one of the important contraindication. This is not part of any scoring that has been popularized till now, because if both the commissures are calcified or if both the commissures are fibrous, when you try to do a balloon valvuloplasty, the least resistance will be not along the commissure, it will be along the anterior mitral leaflet, resulting in leaflet tear. So in my opinion, the selective bicommissural calcification is an absolute contraindication for balloon mitral valvuloplasty. This is a valve thrombus. So in our series, nearly 36% had an Wilkinson score of more than 8. I wanted to drive home the point, just because an echo score is higher, that doesn't mean we are not going to get a good result. What matters most is commissural morphology. Even the leaflet may be calcified, even the posterior mitral leaflet calcified. If one of the commissure is free from calcium, that is enough for getting a good balloon result. So even an echo score more than 12 with one of the commissure being free, still we can do a balloon mitral valvuloplasty. So this is the echo evaluation. I will not get into that in the interest of time, because I just wanted to emphasize in the left upper panel, you can see a heavily calcified mitral valve. Commissures are also calcified. So that is a case for valve replacement. Then in the right lower panel, you can see, although the anterolateral commissure is calcified, posteromedial commissure is free from calcium. So going by Wilkins score, it would be somewhere around 11 or 12. But as far as balloon valvuloplasty is concerned, you can still get a good result because posteromedial commissure is free from calcium, and you are likely to split posteromedial commissure. So these are some of the important septal morphology you should understand. That is the importance. It's not just enough if you look at the mitral valve morphology before assessing a case for balloon. You have to look at the septal morphology. Here you can see here atrial septal bulge is so gross, it is virtually sitting on the right atrium. In this sort of situation, septal puncture is difficult, and you have to take a lot of assistance and use a different technique. So the approaches for balloon mitral valvuloplasty is the standard transfemoral transseptal. That is the most standard approach for transseptal catheterization. If there is any problem with the IVC anomalies or IVC interruption, then we can go transjugular, and retrograde is just an history. So these are some of the technically difficult situations at the level of the transseptal puncture. If it is an abnormal septal profile, very thick septum, bulging intraatrial septum, if there is a septal aneurysm, or if there is a double atrial membrane and severe kyphoscoliosis in dextrocardia, yes, that also, in fact, one of the best way of doing a transseptal puncture or a balloon mitral valvuloplasty in a patient by chance, if there is a dextrocardia with mitral stenosis, is flip-flop the images on the screen. Then you do as if you are doing a levocardic case. So technically difficult situations is one is at the level of the septum, the other one is at the level of the crossing the mitral valve. So what are the situations where you come across difficulties in crossing the mitral valve? That is a critical mitral stenosis when the area is less than 0.5 centimeter. This is because the diameter of the unstretched balloon, whether it is a Inouye balloon or what we use a prototype of Inouye in India, a Kura balloon, it is a 5 millimeter balloon when it is unstretched, because we need to unstretch when you are trying to cross the mitral valve. So 5 millimeter balloon, difficult to cross a 5 millimeter orifice. That is one issue. If it is a small left atrium, there could be difficulty. If there's a large giant left atrium or a thick intraatrial septum or severe submitral stenosis are unfavorable intraatrial septal puncture site. So these are some of the situations you confront resulting in difficulty in crossing the mitral valve. Two critical steps, as I've already alluded to, and transseptal puncture, what are the landmarks? Yes, if you look at the various, literature, there are various horizontal lines, vertical lines going across, along the right atrium. I think best is these landmarks, many a times gives a lot of confusion. So it is basically a fluoroscopic guided, what we do with the pigtail as a reference in the aortic sinuses. And yes, it could be an angio-guided, or it can be, of course, guided by transthoracic, transesophageal, ICE, as well as 3D echo. So, of course, in many situations, particularly when you are doing a left atrial appendage closure, or when you are doing a mitral clip, normally transesophageal echo assistance is very, very important, because today interest of transseptal is not just balloon, it is basically, expanding indications of transseptal catheterization today is an appendage closure or a mitral percutaneous mitral valve replacement or a mitral clip, and even the left ablations. So the views for intraatrial septal puncture is in our practice, what we use is we just start our broken barrow needle and Mullin sheath as a unit from SVC. You just bring it down to the just one space below the aortic root. And what are those views? It could be an AP view, or it could be an RAO 30 and a LAO 40, or a lateral view. The view with which you are most successful is the best view. Just because you are listening to some lecture, you should not try to change your views of puncturing the atrial septum. So what we do in our is LO 40. You can see on the left panel is an LO 40. That means in the AP view, you bring down this broken barrow needle and the Mullin sheet from SVCs, then just it slips and sits across the septum. So in this LAO 40, the pigtail is placed in the aortic sinuses, and you pick up a point somewhere arbitrarily midway between pigtail in the aorta anteriorly and the vertebral column posteriorly, and just have a little clockwise traction on the broken barrow needle, so that tip of the broken barrow needle is pointing towards the left shoulder of the patient, and that is the point where you can go. Of course, this is not a standard reference. Sometimes, depending on the patient, we have to keep altering somewhere between the pigtail as well as the vertebral column. Then you advance this as a unit. Then the other view that we can have is RAO view, as it is shown on the right. So this is how I think septal puncture is basically a feeling. Moment you have a tactile feeling that when once you are puncture the septum, you know that in this particular case you have punctured the septum. That sort of a tactile feeling is appreciated always. Sometimes, yes, in about 10 to 15% of the cases, there could be a difficulty on fluoroscopy alone. You may not be able to puncture the atrial septum. You can always take a transthoracic echo. You can see here the broken barrow needle is seen as a bright structure across the atrial septum. Then you know that you are in the exact plane of the atrial septum. In this you can advance. So even a transthoracic echo assistance can guide your transseptal puncture. Then another thing, another clue is that when your broken barrow needle is indenting on the septum, that is another clue that you are in the plane of the proper plane of the septal puncture. You can always advance. So these are some of the important guided transseptal puncture. So the method of crossing the mitral valve is an important issue. Yes, for just information, in some places, particularly low volume centers where they don't do much transseptal puncture, they can always take an assistance of intracardiac echo and or also a 3D echo. But we at Jayadeva Institute of Cardiovascular Sciences, on a yearly basis, we do about 1,500 balloon mitral valvuloplasty. So that should not be an issue, but still, yes, if there is a problem, then it should always, I think, take the assistance. So there are various methods of crossing the mitral valve: Inouye method, changing the stillates, the loop method, push-pull technique, Swan-Ganz balloon assistance, and modified Mears technique, and our own technique where we introduce the spring guide wire directly into LV rather than into left atrium. So these are some of the methods of crossing the mitral valve. So I think this is where we need to reshape the stillate depending on the LA size. On the left side, these are the balloon, this is the stillate. So if the left atrium is large, then you have to make the loop bigger. If the left atrium is small, you have to make the loop smaller. And if the mitral valve is oriented posteriorly, you have to give a real bend at the tip of the spring guide, this particular stillate. This is very, very important. Many times we have to do as if you do on a PTCA wire. You have to give almost a 60-70 degree bend to the stillate so that it can always cross. So I will not get into the all usual aspects. You can see here. See, whenever you are trying to do a balloon mitral valvuloplasty, the most important, the dilution is also equally important. For an angioplasty, we take contrast to saline 1:1. For a balloon mitral valvuloplasty, the contrast to saline dilution, it should be more of saline, less of contrast. Otherwise, there can be a deflation failure. That's what we are trying to do here. On the left-hand panel, you can see here is the classical Inouye technique. So on the left panel is the Inouye technique, where after a septal puncture, the balloon is somewhere in the upper portion of the left atrium is withdrawn till you get the bobbing moment of the tip of the mitral catheter. So when you are on top of the mitral valve, you get a bobbing moment of the catheter. At that time, with the left hand, advance the balloon catheter. With the right hand, just withdraw the stellate. Then you are across the mitral valve. So on the right panel, you can see here, particularly if the left atrium is large, then you can always cross the mitral valve by a loop method. Suppose when you are trying to inflate, and this is the sort of a picture if you are getting, that means the normal sequence of dilatation is distal first, proximal next. Here what is happening, you can see only proximal is getting dilated. That obviously means you are in the subvalvular apparatus, and you should not try to give an inflation with that sequence of the balloon, what is called impasse sign, because if you give a dilatation in this place with this picture, there can be a subvalvular apparatus can rupture, resulting in mitral regurgitation. In this case, you withdraw the balloon to the left atrium, again recross, ensure that you are not within the subvalvular apparatus. So this is the definition of a successful balloon mitral valvuloplasty. When the mitral valve area is more than 50% of its initial orifice, or mitral valve gradient, less than 3 millimeters or less than 5 millimeters, without creating an MR of more than grade 2 or no major complications. And we have added one more criteria for a successful valvuloplasty is one of the commissures should be visibly split. So then it is called a successful balloon valvuloplasty. If the area post-procedure more than 1.5, or mitral valve area more than 50% increase compared to the pre-procedural orifice, no more than 1 MR, no major complication, one of the commissure visually split. So roughly we get this sort of things. And just I wanted to emphasize, suppose if you are not able to cross the mitral valve by a conventional Inouye technique, what we can do, we can always keep this Mullin sheath near the mitral valve orifice. Then you can introduce this spring guide wire directly into the left ventricle. See that there is an optimal coiling of this wire within the left ventricle. And in fact, this technique now is being followed for either a percutaneous mitral valve replacement. So this is where, suppose even with this, if you are not, you keep the Mullin sheath, if you are not able to put this spring guide wire into the LV, you can always introduce, you can take the help of either a right Judkins or a Tiger catheter. So then these catheters, they have such an angle, they easily cross the mitral valve. Then you can, over that, you can slide the Mullin sheath, then you can introduce this wire. That's how we can do that. So this is the important step of doing a balloon mitral valvuloplasty by over-the-wire technique. When 2/3 of the stretched balloon crosses the mitral valve, then you have to release the balloon stretching tube. That's very, very important. When 2/3 of the stretched balloon crosses the mitral valve, the septum, then you have to release the balloon stretching tube a little bit. We have to withdraw that steel. Then we can see this mitral balloon catheter crosses the mitral valve easily. Otherwise, if you are not releasing this balloon stretching tube, when you are crossing the 2/3 of the septum, whole thing will come back to left atrium. So this is how it can be done. This is by over-the-wire technique. We tried conventional technique for nearly half an hour, 45 minutes. It was not able to cross. Then we resorted to over-the-wire technique, and it was successful. This technique is also useful in patients with a left atrial thrombus, because by over-the-wire technique, even if there is a left atrial thrombus, whether it is an appendage thrombus or a thrombus in the left atrium above the plane of fossa vajalis, you can still use this technique so that you are not playing anything, you are not maneuvering anything in the left atrium, and without dislodging the thrombus, you can always do this balloon mitral valvuloplasty without any risk of embolism. So if large left atrium like 8 centimeter in this sort of situation, you have to, this is what is called the loop method, which I've already described. You have to advance the catheter deeper into the left atrium so that it takes a loop and you can move forward. So this is this is the left atrial thrombus classification. You can see here balloon mitral valvuloplasty can be still done in patients who have got a thrombus above the plane of fossa valis, and if it's an organized thrombus, we can still do that. So these are various types of thrombus. And if there is a thrombus in the body of the LA, it is contraindicated. If a thrombus is along the atrial septum, this is contraindicated. As long as the thrombus is above the plane of fossa valis, yes, it can be done. So you can see here, on the left panel, this is the appendage. You can see here, this is the left atrial appendage and mitral valve is here. So there is a huge gap, a distance between appendage as well as the mitral valve, so that you can resort to over-the-wire technique without dislodging. You can still do that. So you can, this is one of our patient had a left atrial roof thrombus and mitral stenosis is on the left panel here. And also there is a turbulent jet across the septum suggesting severe MS. This is post-procedure. The valve is beautifully split and there is a laminar flow. So also thrombus is unmobilized. So this is another case to show that yes, commissure is free. Severe calcific MS, yes, we can still do, but only thing is one of the commissure should be free. Then can we do a balloon mitral valvuloplasty in patients with MS with more than moderate MR? If MR is coming from the central portion of the orifice, if on short axis color flow, if MR is not from the commissure, if it is from the central portion of the mitral valve orifice, despite MR more than moderate, you can still do a balloon. In fact, after balloon valvuloplasty, there is a better coaptation of the leaflet, MR can regress. You can see here, this is on the left panel, you can see before procedure, there is an MR of grade 2. So after the procedure, MR came down by 1. So this is a submitral disease. Yes, if there is a severe submitral disease, then we have to, I will not get into all the details of how to know about subvalvular disease. A good echocardiography can tell us. You can see here on the left panel at the level of caudal orifice, it's very tight. On the right panel, you can see at the level of the commissure, the mitral valve orifice is around 2, but at the submitral orifice, it's 0.5, suggesting severe subvalvular disease. And you can always do a subvalvular mitral stenosis with initially you can dilate the subvalvular apparatus with the peripheral balloon. Then you can use mitral balloon for mitral. So combining peripheral balloon versus along with the mitral balloon, you can do even patient with severe subvalvular disease. So this is a dextrocardia patient. Yes, you can see flip-flop the image, and you can always do as if you are doing a levocardic mitral stenosis. So if there is a problem of transseptal puncture by a conventional method, method, then transjugular is can be done. Only issue is transjugular. You have to really make a 90-degree bend of the broken barrow needle when you are coming from the transjugular, and you have to puncture one space above the pigtail in the aortic root. In the transfemoral approach, it has to be one space below the pigtail in the aortic root. Here it is one space above. So this is a patient of mitral stenosis with IVC interruption. Yes, this was done with the transjugular approach. When once your puncture is right, then you can, with the same balloon, you can do a valvuloplasty. So I will not, I think probably I will not take much time, because this is just to highlight the importance of complication, acute severe MR following balloon, around 3% in our series. But one point I wanted to drive home the issue is acute severe MR following balloon mitral valvuloplasty. the most important findings and symptoms is not pulmonary edema. Pulmonary edema is not that common. It's only hypertension, hypoxia, and tachycardia is the symptom. So pulmonary edema is least common. This is our experience in the last so many years. We have done close to 20,000 cases. Procedural success is 96%, suboptimal results 3.5, and mortality 0.1%. Restenosis rate at 5 years is 4.5%. So BME, balloon mitral valvuloplasty, is a safe, effective procedure across wide spectrum of patients with MS, and it's a guided, graded, and a gated procedure. And echocardiography during the procedure optimizes the outcome in technically difficult cases. Over-the-wire technique is useful in difficult situations as well as in thrombus type 1A, 1B, and 2A. So complex anatomy is encountered in 1/3 patients. Optimal timing PTMC during pregnancy, that is preferably end of second or beginning of third, is the best period to do. And post PTMC severe MR shows the best result if valve replacement is done on the same day. You should not postpone to next day. Hybrid therapy economizes the cost, reduces mortality and morbidity. Yes, transseptal catheterization holds the key, and the technique with which you are familiar is the best method, best way of doing a transseptal catheterization. Thank you.